rehab progression we went through with her post-operatively to kind of help her return to sport. So by the end of this presentation, hopefully you all have a better understanding of what exactly slipping rib syndrome is, the importance of taking care of rib and thoracic cage conditions like slipping rib syndrome, as it can cause debilitating pain for patients with such conditions, and also to have a better understanding and possibly a framework moving forward if any of you do come into contact with a patient with slipping rib syndrome in terms of what a either conservative approach, pre-surgery, or a post-operative approach to return to sport would be for a patient. So again, what is slipping rib syndrome? That was a question proposed in the offices of our athletic training clinic over at SIUE because no one had heard what it was. Basically, slipping rib syndrome occurs at ribs 8 through 10 in your thoracic cage. So those are your false ribs. So as you can see over here, kind of that blue area, that is where slipping rib syndrome kind of occurs. And basically it is a problem, most oftenly an anterior dislocation of those ribs from the cartilage. Very commonly, people are misdiagnosed with either a intercostal strain or a rib fracture. Most commonly, it is a clinical diagnosis, just because, again, it's kind of ruling out those other more common conditions. And when I was going over kind of trying to find background information for this presentation, the kind of highest level of evidence were surgical case studies. That being said, that isn't a very high, level of evidence, but that was what most of the publications were. So what exactly, or how exactly does slipping rib syndrome occur? A lot of the comprehensive reviews, which were kind of the other most commonly published works about slipping rib syndrome, kind of disagreed on what exactly caused it. Some people thought it was congenital, so it was a malformation of those costal cartilage. Some people thought it was due to traumatic trauma to the thoracic cage. So for our soccer goalie, it tentatively could have been because of all of that diving and high impact on her thoracic cage it was doing. And not always, but very commonly, clicking is something that goes along with slipping rib syndrome. Clicking doesn't always occur, and it doesn't necessarily have an indication on if it's going to be particularly painful or not, but in a lot of athletes, that kind of is a way of differentiating it from some other rib conditions. So how to diagnose it? As I mentioned previously, it is a clinical diagnosis. That is because most commonly slipping rib syndrome will come up negative on your normal imaging, like X-ray or MRI. And so right here we have the hooking maneuver. So essentially that's where you're taking your hand and you're going underneath the rib cage and pulling on it. I don't know if anyone has ever had that happen to you. Even if you don't have an injury, that's going to hurt. And just because it does hurt and you do have an injury doesn't necessarily mean it helps rule out those other differential diagnoses I've mentioned before. And then I did find one study that I found very informative using diagnostic ultrasound for diagnosing slipping rib syndrome. So basically they had 3 different dynamic movements they performed. This first one is the Valsalva Maneuver. Essentially, ways we describe this to our athlete is you're on the toilet going to the bathroom and you're bearing down. And so you're trying to cause that intra-abdominal pressure. So you're going to kind of feel your abs kind of push out a little bit. You're going to feel your back tense up and kind of the same thing on your side. So you're just kind of trying to bring in that abdominal region. So we had a patient, they had patients laid down that had slipping rib syndrome. And so we have the 8th rib right here. I know it's, imaging's not anyone's favorite thing, especially a diagnostic ultrasound. Then we have our 9th rib right here. So we have our intercostal space. And then when they perform the Valsalva maneuver, we have our 9th rib that kind of comes more posteriorly and approaches the 8th rib a lot more. And that intercostal space gets pushed to the back. So in that intercostal space, we have intercostal muscles as well as neurovasculature. So especially if it's pinching in on that nerve, that can be really, really painful. And then the same thing over here, it was with a crunch mechanism. So essentially doing crunches. So they would encourage the patients while laying down, lift up their head and shoulders, and that qualified as a crunch. And so we can see the same thing here. We have our 8th rib, our 9th rib, and then when performing the mechanism, there's almost no space. So that's pinching the intercostal muscles and neurovasculature a lot there. So for the background information, I utilized PubMed. I don't want to overwhelm everyone with my search terms. I did use slipping rib syndrome as a mesh term. There are a lot of other thoracic cage conditions that are similar that were kind of utilized as well. And then I used human subjects, the English language, so that we didn't have to worry about some errors in translation. And then also we use publications from 2010 to present. The reason for that is because slipping rib syndrome has actually been published in literature since 1919. That being said, just because it's been around a really long time doesn't mean it's well established. And a lot of that research are those comprehensive reviews where they rely more on analytical data than actual empirical data. And with that, I ended up with 48 results. Again, a majority of those being case studies for surgical intervention, nothing in terms of rehab or prehab or treatment other than NSAIDs and other analgesic approaches. So for our athlete, we had an 18-year-old Division I female soccer goalie who presented to us in July during summer training with left side rib pain. This was really sharp and excruciating pain. A lot of times it was even nauseating, and we couldn't do anything other than giving her NSAIDs. Even if we put an ice bag on her, that would cause her to be very noxious. So there wasn't a lot we could do there. And she had a lot of clicking present. There wasn't anything that particularly caused her injury to get any worse. It just, some days she'd wake up and it was bad. Some days she'd wake up, it was good. No specific motion made it worse or better. And so kind of what we did was we did that imaging. And as I said before, oftentimes the percent is negative for a lot of different things. There was no substantial findings at all. And we kind of had to play tag between orthopedic and cardiothoracic surgeons. We'd go to an orthopedic surgeon. They said that's more of a cardiothoracic issue. They kick us over and they'd say the same thing. It's more of an orthopedic issue. So after kind of playing tag for a little bit, they kind of came on the assumption that it was slipping rib syndrome. That wasn't based off of anything other than they knew it wasn't an intercostal strain or a rib fracture. And eventually we did find a physician who had experience with slipping rib syndrome, who's willing to operate. It wasn't through network. It actually happened to just be our athlete's grandmother used to work with a cardiothoracic surgeon who had seen it. So basically what they agreed to do is they would have an exploratory surgery, basically open them up and actually see if it was slipping rib syndrome, because that is kind of the only way to confirm. And then from there, based off of the condition, they would try and surgically fix it. So this isn't an image of our actual athlete's surgery, but it's a surgery similar in one of the sources I utilized. So basically, she had her 10th rib was basically wedged up underneath her 9th rib. So it was causing a lot of pressure and pinching on the intercostal nerve, which was what was making it so nauseating for her. So what they did is they sutured around the healthy 9th rib, and then they sutured through the cartilage of the 10th rib. So she had a lot less cartilage on her 10th rib, so it wasn't fully connecting all the way up to the sternum. And so by doing that, they prevented that extra mobility, as well as making sure that it wasn't going to go underneath and start impinging more, for making it more painful. So after the incision site had fully healed, the cardiothoracic surgeon cleared her to go back to full sport. This was in November is when we started treatment. Obviously, she hasn't been doing any activity since July, so we weren't about to just throw her to the wolves there. So we started doing some rehab. Again, as I mentioned, I couldn't find any publication on any particular rehab for a condition like slipping rib syndrome. So we basically treated it like a oblique strain or an intercostal strain, just because the obliques do have attachment sites up there on the thoracic cage. So this first phase, we basically just wanted to focus on stability. So we do have some treatments like ultrasound and ice. And then the two exercises I really want to focus on here is the Valsalva Maneuver. So I mentioned that earlier for the imaging study. The Valsalva Maneuver is normally used more so as a diagnostic test than as an actual abdominal bracing technique, just because it can cause some pain. And if there is an injury present, it can worsen it. But because this athlete's a goalie and she's going to be having high impact, we really wanted to make sure that she was going to be able to absorb all of that pressure. So we thought the Valsalva Maneuver was the best kind of stabilization technique to go with. And then we had her do an isometric dead bug. So as opposed to moving her limbs, we basically just had her stick her arms and legs up in the air, kind of increasing the demand on her core to stay strong and steady. And then in our next phase, we started incorporating strengthening techniques. So while still performing the Valsalva Maneuver, we had her doing a normal dead bug. So we started with the same side. So we would have her bring her right arm and right leg down, touch the ground, and then bring them back up and then move to the other side. Kind of like she's doing in this image here. And then we also incorporated glute bridge, just because the glute is one of the largest muscles in the body, and it's really important for the lumbopelvic hip complex. And since performing the Valsalva Maneuver kind of affects the lumbar spine and the musculature around there, we just wanted to make sure she was capable of keeping that stable Valsalva Maneuver going while also doing the glute bridge. And then in this phase, we also started incorporating biking, just because we wanted to start kind of getting some of that cardiovascular demand back in there. Even though she wouldn't be running around as much as a midfielder, we still thought that was very important since she hasn't been doing anything since July. And then our next phase, we started incorporating just a little bit more challenging strength exercises. So we kept things like the dead bug. We just started adding weight to it. We made the glute bridge one on our heels, so that basically just fires up and causes more demand on the posterior chain of the lower extremity. We increased the time that she was performing that activity. And then we also had her doing planks. These images aren't of our actual athlete due to unforeseen circumstances. We weren't able to get pictures of them doing it, but basically they were performing these two maneuvers just on their knees. And so basically here you're working on the obliques on this side, making sure that they're strong enough to keep the body up so that the body doesn't tilt and kind of make a V there. And then over here, as opposed to the abs, which, a lot of times when people say core or trunk, they think abs, but that also when talking about the trunk, it also includes the back. So we wanted to make sure that she was able to, while still doing the Valsalva maneuver, kind of have strength in her back there. Then we also upped the biking a little bit as well. And then in our last phase, before we, handed her over to our partners in sports performance, we wanted to make sure that we were able to incorporate some power exercises. So in this first activity, it is a med ball diagonal. So basically moving in a functional movement pattern. She started with the ball squatting and then would rotate to the opposite side and kind of lift the ball up. So just as a goalie needs to be able to react and jump up to block a shot, we started kind of incorporating that. And then a more advanced one, kind of incorporating some plyometric exercises. We have this weighted ball toss with rotation. So she would start on one side with the ball, toss it up against the wall, and then she would catch it and then slow it down, decelerate it as it came back to the other side. With all of these exercises that we performed with our athlete, the only time she really struggled was in our second phase when we started incorporating strength training. We kind of attributed that to the fact that she hasn't been doing any strengthening since July, in addition to the fact that the Valsalva maneuver does kind of demand a lot more power and intentional movement. And then as well as the biking in phase 2, just again, because she hasn't been moving around and being active and doing much cardio, as well as the fact that slipping rib syndrome, the ribs affected by it, basically the diaphragm is right behind it, and the thoracic cage aids in respiration as well. So that was kind of a challenge for our athlete as well. And then, as I kind of mentioned before, some of the things that affected how we approach this is slipping rib syndrome has been around for over 100 years, but very few people actually know what it is. It's been documented, but it hasn't been well studied beyond those case studies that are just surgical intervention. And those surgical intervention cases don't really mention anything about rehab after. It just mentions, incidents of having to perform another procedure or if they were able to return to their normal activity. That doesn't necessarily mean in an active population, for example, a Division I goalie, that they would be able to fully return. So that was kind of the importance of making sure that there is something out there in terms of rehab for conditions like this. And then in conclusion, as I mentioned before, I really hope that you have a better understanding of what slipping rib syndrome is. It's just because it is misdiagnosed and oftentimes a missed condition, it's kind of contributed or attributed to those intercostal strains or rib fractures. Although surgical interventions are well studied, that doesn't end there, especially for a more active population. It's really important that we're finding ways to help them easily progress back into their activity with either, it being physical therapy or just if it is with, an athlete and you're an athletic trainer doing those rehab progressions with them as well, especially because this is such a painful condition and an athlete or a patient in general that's diagnosed with this condition or it is not diagnosed with this condition when it is in fact slipping rib syndrome can be in a lot of debilitating pain for a really long time. That concludes my presentation. Thank you all for coming. I'd like to thank my friends and family for supporting me through all 5 years I've been here at SLU, all the faculty and staff, as well as all of my preceptors for making me the best future clinician I can be. And I'd also like to give special thanks to Hannah Daly, my current preceptor, who kind of helped me through this entire process.
Good job, Mason. We do have a question from the chat. Kaylee Jo Edelin is asking, how do you feel that working with this athlete will, in this unique condition, help you in your future career as an athletic trainer?
Sure. So I would say as athletic trainers, our knowledge base is a mile wide, but not necessarily an inch deep. So just kind of having a wider understanding of a unique condition like slipping rib syndrome allows me to better, either suggest that as a possible condition that an athlete might have when kind of having that discrepancy and kind of being able to skip, having that phone tag with a bunch of different clinicians before finally finding someone who's able and willing to kind of perform a procedure to help this athlete.
You want to have any questions? Yeah. Oh, we got a question here.
I think I probably would have waited a little bit longer before we started incorporating conditioning, just because all of the challenges that our athlete faced were in that second phase. And so I would probably focus on that strength first. And then when we moved into that third phase of just making the strength exercises a little bit more challenging for them, I probably would have started incorporating cardio then.
Good job. Okay. Our next presenter. Brittany, do you want to advance your slide quick? You can come on over. We'll take a picture. Excellent. We're ready when you are.
All right. So I did my capstone on effective communication with athletes with autism spectrum disorder. For me, this is kind of an interesting one. There isn't obviously a ton of literature on it, but I think it's something that should be addressed. So kind of get into it. So at the end of this presentation, you guys will be able to describe strategies to use for effective communication with athletes with ASD, understand the need that there is further research that needs to be done and education implemented in our program so that we have a better understanding of it, because it's ever growing that we're going to see athletes with disabilities with how much inclusion is going on nowadays, and we need to be prepared for anything that comes in the door. And then apply these strategies to develop personalized pain skills for athletes with ASD. So autism affects 1 in 44 children in the United States. That number just 2 years ago was 1 in 58. And so now it's 1 in 44, and it just constantly is ever changing. Those with ASD vary in social skill, communication, consistency, and sensory perception. So we know that with this rising high prevalence of children diagnosed with ASD and other forms of neurodivergence, means that the likelihood of us engaging with them in practice, or someone who either knowingly or unknowingly has it, is higher. With this, with the barriers that they have and the difficulties that they face, we have to adapt and be flexible. Thinking of pain scales, they're very subjective. It's very much the patient, on a scale of 1 to 10, that's your pain. For one person, it could be a 5, another person that could be a 10, even if it's the same type of injury, same type of thing. So I think that being able to have adaptive scales and things that are more subject to the person and what they feel will improve the quality of care. And so using these tools include not only educating ourselves, but being adept and using visuals when verbal doesn't work, remaining clear and concise, thinking quality over quantity. You don't need to overly explain something. You could keep it very simple and precise. And then building and gaining trust with our athletes is one of the biggest things. So incorporating care circles and things like that are really useful when working with athletes with autism. So a little bit of background. So in the athletic training profession, we interact with diverse populations, as you know, and we have to do our best to cater to all their needs within our scope of practice. So with this, with an athlete comes a diverse history of disorders, disabilities, diagnoses. The common denominator is they're all still our athletes. But we have to be able to utilize what we do know and stuff that we even don't know to cater to the needs, including those with ASD. 57% of high school students played on a sports team in the past year. All the research that I've done looking up to it, more and more kids are playing sports, more and more kids are doing stuff. But more kids are also being diagnosed with autism every year. So engagement in sports is important for those athletes. It helps them build certain skills that help with their difficulties and learning, doing goal setting and working on leadership skills. The lack of our coursework to teaching AT students about athletes with disabilities is rather low. We're only privy to the medical information that we see on their paperwork. But when it comes to their ability to participate in high school sports, I think that we have to be able to look for other things and be able to see other things, whether it's a coach says something and kind of get into stuff that we might not know. We don't know every disability they might have. Some kids could have ADHD. That's not going to be on their pertinent, physical form for us. So we should have the necessary tools to effectively communicate with all athletes, regardless of their disability status. Methods. So I use Sports Discus, the National Institute of Health Library, and Taylor Francis. I used reputable sources from organizations that focus on ASD since there wasn't a ton of actual literature out there. So that included Autism Speaks, Child Mind Institute, and the Autism Now. I also used a personal source. My personal source had first-hand knowledge of catering to needs of those with ASD and kind of aided in helping finding like the extra material I needed for the composition of this research paper. And then focused on the PICO statement. So I used for my population, it was athletes with ASD. Intervention was communication. There was no comparison, and the outcomes was the strategies. And then the filters, I focus on adolescents age 13 through 18. I've done most of my clinical work with high school athletes. I really enjoy that population. I think they bring a lot of fun to the profession, and they're an interesting group to work with, that's for sure. So inclusion criteria, within the last 10 years, you obviously want the most recent stuff, peer reviewed and inclusion of the PICO statement and those key factors. And then exclusion criteria included studies not relevant to my search terms and studies not relevant to questions. And that's where it kind of got surprising. It's like I put in the search terms, changed them a lot, did all this. It yielded 44 results, but only 3 really made sense to what I was kind of looking into and met that inclusion criteria. So a lot of them focused on like 3 that met it, focused on how AT programs, like I was speaking about before, the students aren't receiving a lot of like information and background for working with athletes with disabilities. So like, as you can see, 70% of AT programs report that students are receiving an entire class on providing care for people with disabilities. That's pretty low though. 30% who did address it only addressed 3 or less of 10 disabilities in the study. The disabilities that they included were ASD, intellectual disabilities, learning disabilities, ADHD, paralysis, cerebral palsy, multiple sclerosis, vision loss, hearing loss, and amputation. The next one was focusing more on how athletes with ASD express their emotions. It's not uncommon for an atypical manner, such as laughing when angry or in pain. And so like, that's kind of, they also talked about devising a personal pain scale, which I think is very important because, the normal 1 to 10 might not make sense to them. So when you design a scale for them, you want to make sure that they understand it, they fully are engaged in it and stuff like that. So I think being able to recognize the key differences between athletes who are neurotypical and those who are neurodivergent is a key distinction when trying to do a full examination on the athlete with ASD. And then the last one, which gave us a lot of stuff, was difficulty understanding and interpreting directions. So a lot of what happens with students with ASD and athletes with ASD, they are very used to routine. They're very used to skill. So when you think about sport, you have practice, you have games, and when you go to your practice, everything's very like in line and order. So in an athletic training room, we could do that too. If we're rehabbing them, like we can maintain order and maintain, step-by-step stuff. So it's easier for them to understand, easier for them to do and be successful in their rehabs. And that comes down to, again, like that remaining clear and concise and maintaining routine regimen is important. And then, so discussion, there's a lot kind of going on with it. Understanding athletes with ASD starts with recognizing their expressions or their lack thereof and kind of like remaining patient with them. You could ask them a question and might not get any response. You might get a very long response that has nothing to do with what you just asked. So like kind of like making sure they understand the question, asking for clarification and stuff like that. Gaining trust is also very crucial. You need to utilize the care circles that includes coaches, nurses, teachers, parents. That's the only way that you're going to be able to be put into that care circle. Just because you're their athletic trainer and you're called out to go take care of them, they might not trust you. They don't know who you are. They don't know things like that. So kind of being able to become on a level with them where they can trust and you can get clear information and you're able to do a good examination evaluation to be able to diagnose any injury and help. Also maintaining that routine again. They don't like change a lot, so you need to keep it consistent. And if you do say like, oh, we're going to start doing, a rehab in 10 minutes, it needs to be in 10 minutes. They're going to focus on it, they're done with the one and they're moving on to the next one in 10 minutes. It's not like, oh, you kind of forget about them and you go working with another athlete. It's like you have to be very consistent. And then educating yourself if the preparation wasn't there for you, which I thought this was really helpful in teaching me a lot of stuff and skills and strategies to be able to communicate. Oh, that really skipped a lot. Okay. So this is kind of like pain scales and what I was talking about. So the first one is kind of based off of the Wong-Baker FACES pain scale, but it's a little more adaptive. It uses colors. It uses more of like a visual aspect, not just only faces and numbers. This is kind of our very basic one that you've probably seen before. This is a color analog one. The color analog one, again, it's using those temperatures like cool. You can explain to them cool's referred to like you're feeling good, and then red's like you're not feeling so great. This is kind of more a personalized one. So if you know your athlete, for example, loves Legos or loves trains, like a train in perfect condition is going to be like on the happier end of it. A train that's in a crash is going to be on the bad end of it. So like you can create scales and create things that they're going to understand more than just the typical, what's your pain on 1 through 10, you know, that type of thing. So that I thought this was a pretty interesting one, more adaptive. And then kind of like implications and limitations to the research was, it's very limited. And tools and strategies are not for everyone. So even though you read something, that might not work for your athlete. Like creating a personalized scale should work, but it might not. So you need to be able to come on the fly, like coming up with other stuff. You know, when you're asking a question and they're not understanding it, you need to think of how could I reword this? How could I just kind of work through this so I can get a clear answer? Because we want to be able to do an examination well or an evaluation well. We want to be able to help them to the best of our abilities. But, you know, if you're doing a squeeze test, they're showing you no indication that they're in pain whatsoever, but then you show them a scale, like, and you ask them 1 to 10, they say, oh, it's a 2, but then you show them like a scale with the faces and they're pointing at the red face. It's like, they're clearly in pain and they just didn't know how to express that properly. But they were able to express it in their manner. And then remaining adaptable, I think is just the biggest thing and most imperative, because when it comes down to it, you need to use your best judgment with any athlete. You're using your best judgment on what you should do. So if you think, you know, a lot of the hard stuff that comes with working with athletes with ASD, I think comes down to kind of like if they have a head injury, do they have a concussion? The SCAT-5, you know, asks a lot of those questions like, are you feeling tired? Are you feeling foggy? That could be their typical day. And I know it says on the top of it, like ask if, you know, if you have a headache every day, then you need to put 0. They might not understand that. So it's like, you need to be more adaptive, but you also need to use your best judgment to be able to say, you know, yes, I think you have a concussion, or is that just a safer way to manage that athlete until you can get a more clear understanding of them. Future recommendations, further research with larger sample sizes, questions to be posed specifically to like athletic trainers. Do you feel you understand athletes with ASD? And do you feel prepared to work with autistic athletes? A lot of this research, like the programs, it was like 66 directors of programs were surveyed, and only 11 of them like had incorporated a course for their athletes, for their students to understand like athletes with disabilities. And so ultimately, like, do you feel prepared to work? I know I didn't necessarily feel prepared. I knew a lot of stuff, and kind of like working, like volunteering in hospitals and things like that. You kind of adapt to working with many different people, and we work with many different athletes. But I think this for sure helped me a lot more in kind of understanding like the gap that we had in our education. And then further incorporation of disability courses in the curriculum for athletic trainers, and more exposure to athletes with ASD as part of our clinical competencies could be nice. Obviously, we're not always going to know, but it could be useful. And then in the conclusion, with the high prevalence of children diagnosed with ASD every year, we're going to see more kids with disabilities, or none other than ASD. We're going to see more kids with ADHD. We're going to see lots of different things that we're going to have to adapt with. And so we need to be able to educate ourselves, use visual aids, be clear and concise, and gain trust with those athletes. For acknowledging, I have quite a few acknowledgements. So I'd like to thank Dr. Tony Bretbach for my entire time in this program, that's for sure. He's been a great supporter, and he helps with this Capstone project. Amy Barbaglia-Wagner for help with resources relevant to my topic, and proofreading of my project was very helpful. John Rabel for assisting with revising and proofing my project and continual support throughout my entire time in this program. Maddie Kavanaugh for her continual support, especially in the last most formative years of the program. The staff and faculty of the AT program for shaping over the years and guiding me to where I am today. And my preceptors, Catherine Lewis, Emily Costable, Kristen Jeans, and Matthew Peterson for all the help they've been over the years. And then of course, my family and friends for their unwavering support. Thank you guys. Emotional.
Questions, anyone? I have a question for you. So,
yes.
So in in your experience, did you find as you were doing this research that it was helping you kind of adapt your interaction style as you were learning more?
100%. So like kind of with doing research and, coming across an athlete who, we had known like had difficulties with stuff, and, you hear stuff from coaches, like this athlete has this learning disability. It's like, oh, well, I didn't know that. You're not always going to address it. You're not, because if they don't want to tell you, they don't need to tell you, but having that in the back of your mind and being able to, adapt into a different way, and like without, like, they're not going to know that you knew that, but if you know it and you're able to kind of like adapt questions and adapt how you're working with them and being able to get clear answers from them, you can just see like the trust being built with those athletes. And you see them more often around the athletic training room, and they know that they can come to you for help and that you're not just going to sit them out or this or that. And so I did see that a lot, especially being at Marquette with 2,000 kids that go there. So we had tons of athletes, over 1,000 that play sports. You see a lot of different faces, you see a lot of different people, and being at such a large school, it's imperative, and like, you're going to see different people. So yeah, I did make a lot of adaptations, that's for sure, for the research.
Nice work, Brittany.
Thanks.
Sure, first here. When you are.
Awesome. Okay, hi everybody. I am Maddie Kavanaugh. Thank you all for being here today. And I did my capstone on the FIFA 11 Plus and if it is effective as a hamstring injury prevention program. These are my learning objectives. Just a little bit of background information. Hamstring injuries are a very prevalent injury and also time-intensive injuries for athletic trainers. They take extensive treatment, usually rehab periods that last over a month, and they also have a very high reoccurrence rate. Nordic hamstring exercises are typically used as an injury reduction technique. So they are a hamstring exercise that focuses on the eccentric portion of the contraction, and that really helps strengthen our hamstrings to help with that injury reduction. The FIFA 11 Plus injury prevention program is used as a warm-up for soccer athletes. It also has the eccentric hamstring training component as part of the warm-up, and it also incorporates sport-specific exercises for soccer within the program. So this really led me to question if FIFA 11 Plus can be used as a hamstring injury prevention program with the use of those Nordic hamstring exercises. So the purpose of my study was to evaluate if the FIFA 11 Plus injury prevention program is effective at reducing hamstring strains in male soccer athletes aged 17 to 23. A little bit of background on this topic. Hamstring injuries are the most common non-contact injury in any athletic sport. Those non-contact injuries come from sprinting, cutting, coming to a quick stop, a quick start, or any change of direction. Eccentric hamstring contractions hamstring injuries usually happen during the eccentric phase of a hamstring contraction. So you're very prone to injury during that eccentric contraction. According to the NCAA surveillance data from 2014 to 2019, 7% of all injuries reported were hamstring injuries. And that is the second most reported injury, second to only lateral ankle sprains. Our Nordic hamstring exercises are used as an injury prevention technique as they help strengthen, and then they also prevent injury and re-injury due to that strengthening component. The FIFA 11 Plus is used as a warm-up and a lower extremity injury prevention program in soccer. Most of the research is done with ACL injuries. So there is actually a 4.25 times reduction in the occurrence of ACL injuries with the use of FIFA 11 Plus, but there is very little research done with hamstring strains. So that leads me on to my methods. In March of 2022, I did this search. I searched PubMed. My PICO statement included the following components. My patient population was male soccer athletes. My intervention was eccentric hamstring training or FIFA 11 Plus. My comparison was just the lack of eccentric hamstring training or FIFA 11 plus. My outcomes were hamstring strains, and my timing was over the course of a soccer season. I did apply these age filters to kind of get me into that range of 17 to 23. My inclusion and exclusion criteria are up on the board. So I wanted articles that were peer-reviewed, full text in English, published in the last 20 years, included my PICO statement, evaluated male soccer, included eccentric hamstring training as part of FIFA 11 plus, study designs of clinical trials, randomized control trials, systematic reviews, or meta-analysis. And then the mean age of the study fell within that range of 17 to 23. My exclusion criteria included alternative primary outcome measures, and then they tried to report it back to or relate it back to injury prevention. I did not look at those ones. And then they also evaluated interventions other than the FIFA 11 plus as an injury prevention program. So after running all of that, I found 14 articles were found, but only 3 met my inclusion criteria. So the first one was Grooms et al., and that was a prospective cohort study that studied 1 college men's soccer team, and that yielded 41 athletes. They found that their muscle strain injury rate in the season that they did not use FIFA 11 plus was 6.2 per 1,000 athlete exposures, while the muscle strain injury rate in the season where they did use FIFA 11 plus was 0.55 per 1,000 athlete exposures. They also found that the time lost due to thigh muscle strain in the season where they did use FIFA 11 plus was less than the season where they did not use FIFA 11 plus. My second article was Nauni Garcia et al. That one was a cohort study, and that looked at 2 amateur men's teams, and that yielded 86 athletes. So they found that there were 35 hamstring injuries in the group that did not use FIFA 11 plus as a warm-up, and there were only 18 hamstring injuries in the intervention group that did use FIFA 11 plus. And then my final result was Silvers Granali et al., and that one was a randomized control trial that had 65 Division I and Division II men's soccer teams, and that had 1,525 athletes. There were 55 hamstring injuries in the control group, which did not use FIFA 11 plus, and 16 hamstring injuries in the intervention group that did use FIFA 11 plus. And that is a 2.74-fold reduction in the likelihood of incurring a hamstring injury with the use of FIFA 11 plus. So just kind of to summarize all of that, our hamstring injury rates decreased with the implementation of the FIFA 11 plus injury prevention program. The time lost due to injury was also decreased with the implementation of the FIFA 11 plus. And these articles that I found do align with the previous research surrounding Nordic hamstring exercises and hamstring strains. So all of these, with the use of the Nordic hamstring exercises within the FIFA 11 plus, it aligns with all the previous research that had been done studying Nordic hamstring exercises in isolation. Moving on to a little bit about what a warm-up is. So I used the National Academy of Sports Medicine criteria for a warm-up. The purpose of a warm-up is to optimize performance, prevent injury, and prepare an athlete psychologically. There are a lot of physiological effects that happen during the warm-up that really helps the body to increase its adaptability to the imposed demands of the sport. The components of a warm-up typically include submaximum activity, stretching, sport-specific activity, injury prevention techniques, a gradual progression, and an increase of speed. The FIFA 11 Plus is a 15 exercise, 20-minute program that has 3 parts. So our first part is running exercises and active stretching. The second part is 6 strengthening exercises that focuses on core and leg strength, balance, plyometrics, and agility. And then part 3 is running exercises at a moderate to high speed that also incorporates planting, cutting, and bounding movements. So this graphic is just a basic overview of what the FIFA 11 Plus is. So the setup of FIFA 11 Plus is on a soccer field, and it has 6 pairs of parallel cones, 6 meters apart. The athletes do their exercises on the inside of the cones and then just jog back on the outside of the cones at a moderate speed. So these are the exercises of part 1 of FIFA 11 Plus. So for our first exercise, it is starting at our sub-max speed at half speed, and it's just running straight down the cones. For exercises 2 and 3, these are active stretching with running to a cone, doing a hip in or a hip out movement. Really get that active stretching into your warm-up. And then exercises 4, 5, and 6 really begin our sport-specific movements with running to a cone, circling a partner, getting a little bit of contact in with your partner, and then also running forward and backwards, kind of picking up that speed. As we get into part 2, we have 6 strengthening exercises, which all get into our injury prevention techniques. So this is actually there are 3 parts to this second part. As it advances through, as the athletes get more used to, as they get more used to the program. But for this, I'm only showing the first part, so like the beginner phase of FIFA 11 plus. Our first strengthening exercises is a plank. Our second is a side plank. Our third are those Nordic hamstring exercises, which I really evaluated. Our fourth is a single leg stance while holding the ball. And that actually gets progressed to single leg stance while throwing a ball back with your partner. The fourth is a squat with a toe raise, which progresses to lunges and one leg squats. And then our last one is vertical jumps, which progresses to lateral jumps and box jumps. And then finally, part 3 of FIFA 11 plus is just increasing that intensity, increasing that speed. Our 13th exercise is running 40 meters across the pitch at 75 to 80% of our maximum pace. Our 14th exercise is bounding for both height and for height and length. And then our final is running with planting and cutting, making sure we're getting plants on both the right and the left side. We are really just increasing the intensity with this sport-specific exercise at about 80 to 90%. So they are ready for athletic competition at this point. Throughout this progression, they are really helping athletes help their muscles adapt to slower speeds to those higher speeds. The balance is helping increase kinesthesia and increase proprioception of the body. The Nordic hamstring exercises are really there to help increase strength of the hamstrings. And then the more running, the more bounding, planting, cutting that we are able to do, it helps the athletes' bodies increase to their imposed demands. So due to the neuromuscular adaptations that occur during warm-ups, hamstring injuries are reduced with the use of FIFA 11 plus. A couple implications and limitations. These studies may not be reproducible in a real world situation. A lot of the Nordic hamstring exercise studies were studied in isolation. We cannot say that, oh, just go do Nordic hamstring exercises. We need a comprehensive workout program for our athletes. The results provide a great basis for injury prevention, but also cannot guarantee injury prevention. And then the FIFA 11 plus is a soccer-specific program, which limits its generalizability. There is a lack of research in other sports, and soccer is really the only sport that has a standardized warm-up program. So that also leads me into my future recommendations. For one thing that we can look at in the future, the timing of intervention of Nordic hamstring exercises can be looked at within a workout. Is it best utilized before a workout, during a workout, or after a workout for the best results? There are also long-term effects. We can also look at the long-term effects of eccentric hamstring exercises. It may change the muscle makeup of our hamstrings. We don't know. We should look at that. There needs to be more research on the relationship between the FIFA 11 plus and hamstring injuries. Is it actually FIFA 11 plus that is causing these hamstring injury rates to go down? We don't know. Let's look at that. There are also only 3 results that came up that met my inclusion criteria. We just need a little bit more research on it in the future. And then finally, all sports should have a warm-up program that is standardized like the FIFA 11 plus. If we are able to take the principles from the FIFA 11 plus and apply other sport-specific moves from other sports, we may be able to prepare athletes better for their own competition and reduce hamstring strains in other sports. So just in conclusion, there is a lot of room for growth within sports and warm-up programs. If sports model a warm-up program off of the FIFA 11 plus, it is imperative to have sport-specific moves to prepare, to create that connection with the body and the sport in the warm-up. And we should adapt the FIFA 11 plus to other sports to create an alternative warm-up and injury prevention programs that can reduce the incidence of hamstring strains across all sports. Thank you, guys. I'd like to thank Katie and Tony for their help with this capstone project. And then I also want to thank the staff at the athletic training program and all my classmates, especially for keeping me sane this year. It's been a hard year, so appreciate you guys.
Question?
Yeah, I had a question. So I thought it was interesting that, so you said it decreases the likelihood of hamstring injuries, but it was also decreasing the time that people lost due to injury.
Mhm.
Did any of your research like explain why that was? Or like...
I did not find any like reasoning for that. When in that article, it really just said like, oh, this is the time lost due to their injury. This is this is how many injuries they had. This is what, like, this is when they came back, and this is like the rehab time. So it didn't really explain that. But that is also a great future recommendation to look at.
Yeah, and another thing, being the fact that this is kind of a branded intervention, right? It almost could be something you could put into their electronic medical record, keeping track of the students who are doing that. And that way you can take some of your epidemiological data and, look at it, create an analysis of that.
Yeah.
Excellent.
Do you have a question? Sorry.
Would you, based on your research,
I would. I think they, historically, it's had a really good ACL, the English. The research done on ACL injuries kind of speaks for itself. And I think that I do want to get into research in the future. So kind of implementing this and being able to study lower extremity injuries, I think would be really cool.
oh, sorry.
I knew you had it.
Yeah.
Thank you so much.
Slide advantage.
So I did my capstone on label repairs and kind of looking at if external rotation ever fully returns. I wanted to kind of go more in depth on one of the most common complications and complaints that athletes have after shoulder label repair, which is regaining external rotation. Oh, we've got to flip this. So the learning objectives kind of that you'll be able to do at the end of this presentation is describe methods used to surgically repair labral tears in its anatomy, ability to effectively use information from this PowerPoint to facilitate your post-surgical rehab, and then kind of describe best methods used to fully regain external rotation post-labral repair. So kind of the purpose of this, I guess, project that I did, decreased external rotation range of motion is a common complaint following shoulder labral repair. And then in this critical analysis, I researched the clinical results as well as methods used to increase external rotation range of motion following arthroscopic labral repair. Many athletes do complain not regaining full external rotation post-surgery, or if they do regain it, they get it very far into their rehab. So I kind of wanted to look and see if there were any other methods or techniques used to help them get external rotation back at a quicker rate while keeping the surgical repair in a safe position. So just to give you a little background of shoulder anatomy, it is a ball and socket joint. It's stabilized by muscles, ligaments, and the capsulolabral complex.
the labrum is a fibrocartilaginous structure that helps deepen the shoulder socket. And the labrum does have poor vascularity in some areas, causing there to be a decrease in healing rates. So the main muscles stabilizing the shoulder is like our rotator cuff muscles. And then for repairs, you do need to be cognizant of where the tear is, as well as the repair, as the healing rates may be delayed due to the low vascularity. So then kind of the two tears that I looked at in this research were slap tears, also known as superior labrum anterior posterior tears, and Bankheart lesion. So you have four types of types of a slap tear. So the first type would be just degeneration and fraying, and then the fourth most severe type would be full tears extending into the bicep tendon. And then Bankheart lesion occurs when the labrum pulls off of the front of the socket, and can also have bony defects in more severe cases. There are also four types in Bankheart lesion. So the most basic one would just be the tear off the front of the socket, and then the most severe would be the one with bony defects that will most likely have to be removed during surgery. So then some more background. So mechanism for injury on Bankheart and slap are somewhat different. Slap tears are usually acute and can happen with a foosh, arm tackling, or any sudden force. So a football player like pushing up against someone, that force pushing their shoulder back commonly makes a slap tear occur. Bankheart is usually more due to like recurrent shoulder dislocations, but slap tears can be due to chronic dislocation. Not dislocation, but like chronic injury. And then your surgical repair, arthroscopic repair is done by placing anchors in the glenoid fossa and then passing them through the labrum, approximating the labrum back to the glenoid fossa for a slap tear. And then Bankheart lesion, you're really just trying to bring all of the anatomical structures back to their normal positions. And then some people, I know in older populations, they do have alternative methods of just rest, immobilization, anti-inflammatories, or cortisone shots. And then for methods, I researched studies looking at post-surgical arthroscopic labral repairs and the results, as well as complications that were related to the repairs. My search did include multiple types of labral repairs. I couldn't really focus on just slap tears or Bankheart lesions. There's not that much research in regards to, getting external rotation back. And then the sources I used were PubMed and Google Scholar, and I limited it to English and articles published after 2000. I had to go pretty far back to get a good amount of research due to the lack of actual research done. So kind of the results. Following research studies have shown there are many factors that contribute to increase in external rotation, range of motion post-labral surgery. So early mobilization, surgical technique, reduction of post-operative pain, and then consistent physical therapy. So accelerated rehab has showed a faster improvement in regaining 90% of final end range external range of motion. Surgical technique between conventional vertical knot and the horizontal mattress. The horizontal mattress actually showed better range of motion results in external rotation at the side, internal rotation at abduction, and then total range of motion at the last follow-up compared to the conventional vertical knot. Reduction of postoperative pain can be accomplished by movement to prevent stiffness and NSAIDs if needed. Some doctors do prescribe opioids or some type of pain relief, but a lot of athletes I know, and I feel like a lot of people I've had experience with, don't commonly take them. And then for your physical therapy, you have 3 phases. Your first 0 to 6 weeks, you are just going to protect the surgical site, achieve range of motion goals, which can be done active assisted as well as active. And then phase 2, which is 6 to 12 weeks, patient education of activity limitation, range of motion, and begin rotator cuff and scapular strengthening. And then your final phase 3, which is 12 to 24 weeks, it's really tailored to the athlete and the sport they play. So focusing on neuromuscular training, strengthening, endurance, power, and your dynamic stability. As a discussion, factors that influence a patient's ability to regain full external rotation are mainly based on the provider and/or so not just the surgeon, but also the person who is completing rehab with the athlete. Surgical techniques, rehab plan, early mobilization, and educating patient on goals and helping them achieve those goals are like key factors that I found in this research that will help have them regain their external rotation. And then reducing immobilization time post-surgery. Studies have shown that decreasing immobilization time reduces post-operative pain, as well as an accelerated external rotation. I think communication between professions can spark the possibility of early range of motion. As of right now, I know a lot of clinicians do like to keep athletes kind of immobilized for at least the first 6 weeks usually, but they're like moving it down to like 4 weeks as of right now. And then athletes commonly work with are like very competitive. So if you set goals or if you set things for them to aim for, it would be like a good driving force for them to actually achieve those. And then post-operative pain can cause an athlete to not want to move their arm. So, addressing the post-operative pain and finding kind of good methods to reduce that will also help achieve an external rotation. And then conclusion, there's no exact science to what I found. There's like not one answer that is just going to overall fix athletes losing external rotation or taking a very long time for them to get it back. It is a constant problem following labral repairs, and patient education is key. Keeping them informed on goals they should be striving for, and the risks that come with accelerating too quickly can aid in completing rehab as well as maintaining a healthy surgical repair. So I feel like as like athletic trainers, kind of helping athletes through their rehab and like not allowing an athlete to go super far out of like their protocol is going to help like lead to a healthy recovery as well as reduce the possibility of early injury following surgery. And then those are just my references. I just want to say thank you to my professors, fellow classmates, and family for assisting me throughout my career at SLU.
Question.
Is there any way you can increase vascularity to the area to help boost?
I wouldn't say there's a particular way that you can increase vascularity just because it's a fibrocartilaginous structure. So it just doesn't have good vascularity. It's not like you can do, muscle pumps and you're going to like have blood flow straight to it. It doesn't really work like that.
Yeah. Okay, so our next presenter is Katie Whissy. If you didn't happen to know, she's a pretty good track and field athlete. She recorded her presentation, but she is actually with us. And the AV in this room is very, very interesting. So I am going to mute this microphone.
Hey guys, just so you know, I cannot hear anything if it is not spoken directly into the microphone. But hello, I am currently calling in from Richmond, Virginia. We are at track practice right now, but as Tony mentioned, I am an athlete at SLU, and this topic specifically hit real home to me because it was not only something that a lot of individuals I know experience, but it was something I went through. And I thought it'd be important to share with you guys. Hi, my name is Katie Whissien, and I'm sorry I couldn't be there in person today, but today I'll present on COVID-19, adolescent athletes, and the mental pandemic. So at the end of this presentation, attendees will be able to understand the effect of the COVID-19 pandemic lifestyle on adolescent athlete mental health,
recognize signs and symptoms of mental health decline, and apply what is learned to clinical practice. To introduce my topic, when the lockdown first began and events were quickly being put on hold, I recall immediately feeling panic set in. As an athlete myself, my whole season was suddenly paused for the unforeseeable future. I felt my mental health decline each day, for I did not know who I was without athletics. The sudden loss of identity, rigid scheduling, and teammates to exercise with left me alone and very insecure. Adolescents, already experiencing a time of significant change, were extremely vulnerable when the COVID-19 pandemic drastically shifted the living situations and daily routines. Mental health was not safeguarded. Athletes, especially those who strongly identify as athlete, were especially susceptible to mental health decline during the pandemic. So the general impact of COVID-19, the coronavirus pandemic and subsequent public health measures have significantly disrupted the lives of individuals around the world. Because this was a global pandemic, the widespread nature of the virus left no individuals hidden from the effects of the crisis. The lower fatality rate of COVID-19 allows for more survival. Although this is a good thing, this leaves the recovered individuals to face the psychological consequences of having a pandemic virus. There's copious evidence from previous epidemics to suggest that individuals who recover from acute viral illness will possibly experience significant mental anguish and go on to develop psychiatric complications. Now, mental health in adolescence. Globally, 10 to 20% of adolescents suffer from mental health conditions. As children and adolescents are in a critical development period, half of all mental disorders develop before the age of 14 and 75% manifest by mid-20s. This is a stage of sensitive psychosocial development, and that exposes adolescents to psychological distress of major changes, which may lead to long-term consequences. Limited mechanisms of resilience and coping leave these individuals vulnerable to developing anxiety disorders and high levels of stress. Young people must be provided with tools to cope in order to adjust in times of distress and stay resilient and mentally well. Additionally, with the always advancing technology, adolescents are spending way more time on electronics and have greater access to social media than ever before. Studies have shown that internet overuse can lead to mental or behavioral problems and cause disorders and mood dysfunction. COVID-19 and adolescent mental health. So initial evidence suggests that the coronavirus pandemic can be classified as a traumatic experience for young people. Although this virus targeted an older population, adolescents were not protected by the social distancing, school closures, and job loss, financial and housing instability, and isolation, all of which influence this critical period of growth in adolescence. Schools often provide direct access to mental health services, so school closures have cut off the support network during a time of heightened isolation and loneliness. So the majority of evidence suggests that depression or depressive symptoms worsened, along with heightened anxiety as a result of COVID-19 measures when compared to pre-pandemic numbers. Suicidal ideation also increased during the pandemic when compared to pre-pandemic numbers. Now, adding athletes into the mix, an estimated 8.4 million of the 15.3 million US high school students participate in interscholastic athletics. Individuals who hold heavy attribution of their identity to their athleticism are at most risk for suffering poor mental health when cut off from their sport or going through significant transitional periods. Although athletes are often praised for their mental toughness and resilience, a loss in access to the sport may prove difficult for athletes who have this strong athlete identity. As seen in the literature, a sports injury causes a plethora of psychological and emotional reactions in response to the injury itself, the rehabilitation process, the return to competition, and fear of relapse. So athletes going through this injury period have heightened feelings of depression and anxiety. The cessation of athletics during the COVID-19 pandemic have forced athletes to experience these same feelings in a non-traditional sense. So the literature searched for peer-reviewed articles investigating the effect of the COVID-19 pandemic and lockdown on mental health in adolescents and athletes. The search yielded 22 articles that included full-text journal articles within the last 4 years in English. I narrowed this down to 8 studies that met my inclusion criteria and were included for analysis. There were 3 cross-sectional studies investigating the negative impacts of COVID-19 on mental health. in adolescents and athletes, and 4 systematic reviews exploring the impact of COVID-19 on mental health outcomes in adolescents. This is just a excerpt from my table, which shows the study designs and conclusion. If we look just a summary of this, all studies found a negative impact on youth mental health, particularly symptoms associated with depression and anxiety. So the majority of publications featuring the study found that depressive symptoms were heightened or worsened during the pandemic. The US CDC estimates that nearly 60% of US adults had depressive or anxious symptoms by June of 2020. As noted by Mehrali et al., pandemics cause stress, worry, helplessness, and risky behavioral issues such as substance abuse, suicide, academic issues, especially among adolescents. Additionally, these studies suggest that a severance to physical activity is a dominant risk factor for depression during the pandemic. So to be able to recognize a mental health decline in a future patient and refer as needed is essential to preventing this risky behavior and potential harm. With more research, the prolonged effects of isolation and pandemic behavior can be determined. It would also be significant, I think, to compare the feelings experienced during the COVID-19 lockdown to athletes who have finished their career and end their sport. Because when individuals who have been athletes for the majority of their life all of a sudden finish their career and are cut off from their sport again, I would be curious to see if they feel similar experiences and loss of identity. I thought I would just end it with a discussion on the signs and symptoms to look for. You'll see that individuals who have mood disorders or developing mood disorders may have lower sad moods, often with crying episodes, irritability or anger, feelings of worthlessness, helplessness, and hopelessness, eating and sleeping disturbances, a decrease in energy and activity levels with feelings of fatigue, social withdrawal or avoidance, negative thinking, thoughts of suicide or death ideation, whereas you might see anxiety symptoms as well. This would be excessive worry or fear, sleep disturbances, changing in eating habits, feelings of general uneasiness to complete immobilization, fear that one is dying or going crazy, a pounding heart, sweating, shaking, impaired concentration, or feelings out of control. I got this from the National Federation of State High School Associations. In conclusion, athletes may be experiencing a greater adverse effect than their non-athletic counterparts, with demonstrated increases in depression and anxiety responses as a reaction to the COVID-19 pandemic. When treating an adolescent athletic population, mental health is an important consideration to execute a more complete care plan now more than ever. I would like to thank Tony Breitbach and Katie Sniffen for their assistance throughout this process. I would also like to thank my family and friends who helped me through the pandemic. Thank you. Hi, my name is Katie Whissien, and I'm sorry I couldn't be there in person today.
So when the pandemic hit in March, I was actually a week away from starting my outdoor track and field season. And all of a sudden I was at home for months and was unable to train with any of my teammates, which although track seems like an individual sport, you are very heavily affected by what your teammates are doing. So all of a sudden I was practicing alone at home with no one. and I felt personally a negative decline in my mental health. I was exhibiting depressive symptoms and anxiety heavily increased. But once I was able to return to sport and even just practice with my teammates for the first time, I felt more at home and able to use my athletics as a way to cope with all the negative feelings. That is a great question, Grace. I think obviously the first step to, as athletic trainers, I think our first step is recognizing a mental health decline in our athletes. I felt it was important to include the signs and symptoms of depression, anxiety, because those were the two main symptoms felt during the COVID-19 pandemic. So not only recognizing those symptoms, but checking in on your athletes, referring them to the correct healthcare professional, making sure they're getting the treatment they need and care they need. But I think one of the biggest things is checking in. We are some of the healthcare professionals that see our athletes most often. They don't go to the doctor every day, but they may see us every day. So it's important that the relationships we build with them are used to better care for them from not only a physical level, but emotional and mental aspect. I do think mental health baselines, especially in pre-participation exams, are extremely important to recognizing early symptoms. However, I think there needs to be continual checkups and probably more in-depth conversations with athletes, because some athletes know on the pre-participation exams that if they answer certain questions a certain way, they may be brought in for further questioning. So I do find those questions extremely important to include in a pre-participation exam, but I think there needs to be more frequent analysis of athletes.
So let's all take this chance to give Katie a round of applause. Okay, looks like she's actually out at the track. Okay, so next speaker is Amra.
Hello, everyone. I'm doing my capstone on a case study that I did this year about the effects of blood flow restriction training on range of motion after ACL reconstruction. Got it. Okay, a little bit about our learning objectives. Hopefully by the end of this presentation, everyone will be able to describe the primary goals of rehabilitation after knee surgery, understand the effects and benefits of blood flow restriction therapy as it applies to the ACL reconstruction rehabilitation, and apply the effects of blood flow restriction training to other rehabilitation programs as they would be used in practice. Okay, to start off, so ACL tears are generally treated with ACL reconstructions, followed by a long rehabilitation process before the athlete can return to sport. Some of our general goals, which I'll go a little bit more in depth into, include regaining full range of motion at the knee, improving muscle strength, controlling pain and swelling. So blood flow restriction training helps us address a good amount of those goals that we have. So some of the benefits of blood flow restriction training involve strength improvements, improving quad activation, and controlling pain. So a lot of these studies that I did research on compared high intensity resistance training to blood flow restriction accompanied by low intensity resistance training. And it found that there was comparable strength improvements between the two. So this provides us with a really cool tool that we can use for those patients who come out of surgery and are not able to lift at those heavy loads to get those hypertrophy gains. So we can use this BFR with low load exercises that they're able to do. So our patient problem, which I will get into again in a little bit, we had a loss of range of motion of their extension after their ACL reconstruction, and we had some difficulty gaining that back. So a little bit more about those goals. Like I mentioned, we want full range of motion in both extension and flexion at the knee. We want our patient to be fully weight bearing, recovery of neuromuscular control, restoration of muscle strength to both the knee extensors and knee flexors. And then eventually we want to return them to the activity level and function that they were at before the injury. So one of the most common complications that we can come across during this rehabilitation process involves losing extension. So a loss of extension of 5 or more degrees is directly related to abnormal gait, which can then further lead to patellofemoral pain and quad weakness. So aside from this anterior knee pain, the muscle imbalance can also lead to re-injury if the athlete returns to play without that full range of motion back. So a little bit more about what blood flow restriction training is. Basically, the physical therapist or the athletic trainer or whoever is executing this treatment will place a cuff proximally to the joint that they are targeting. So for most lower limb treatments, we're going to place it pretty high up around the thigh, and it is used to impede venous blood flow from the limb. So the cellular mechanism behind blood flow restriction training is not really known at this point, but what it does is it'll fatigue the muscle a lot more quickly so that the patient can do more simple exercises and less loaded exercises and still benefit from those gains. So like I mentioned previously, it provides identical or very similar strength gains to heavy load resistance training. There was also several studies where it discussed how it decreases pain both during the treatment while they're doing those exercises and also for a period of time after the exercise. And it also decreases joint stress. There was one study that briefly mentioned range of motion. It wasn't their main focus, but it did conclude that in the heavy load resistance training group compared to the BFR group did have a 78% increase in range of motion in comparison to 48% in just the heavy load group. It just, like I mentioned, it discussed range of motion in general, not specifically extension. So we wanted to find out if the blood flow restriction training can be used as an aid for regaining extension range of motion after ACL reconstruction. So a little bit more about our patient. He's a 23-year-old male basketball player that underwent ACL reconstruction and meniscus repair about 9 weeks prior to the start of the study. So basically our issue was that we were stuck at around 10 to 12 degrees of extension before rehabilitation. He would gain a few degrees after we did rehab, and then we'd kind of be back the next day for rehab and he'd be back at that 10 to 12 degrees. So that was one of our goals that we wanted to address, was not only gaining that range of motion from the start of the therapy to the end of the therapy, but also retaining it and keeping it for that next session. So we previously had tried many different things. So we tried a bunch of different passive stretching techniques, different range of motion exercises. We used the joint activation system brace. We tried soft tissue mobilization, joint mobilization, and it wasn't really getting us anywhere. So we decided to see if he would benefit from BFR, as we hoped it would help with his quad activation and then eventually lead to him gaining his range of motion. So basically, our plan was to have the patient undergo blood flow restriction training twice a week. It'd be a 30 to 40 minute session following his normal PT sessions that he was receiving twice a week, which lasted about 45 to 60 minutes. So the trial exercises that we kind of began with were straight leg raises, short arc quad, long arc quad, and bodyweight squats. And then after that initial evaluation to make sure that he responded well to the treatment, we progressed those to a little more difficult exercises as well. So range of motion was measured both before the physical therapy session and then again after the blood flow restriction therapy session. And we also took pain ratings on an NPS scale. The remaining 3 days of the week included the athlete visiting the athletic training room for rehabilitation exercises supervised by the athletic training staff. As for applying the cuffs, we used a perceived pressure rating. So we would have the patient rate his perceived pressure. Our aim was to have it at a 6 to 7 out of 10 which was typically about like 2 or 3 turns of the cuff as instructed by the maker of the brand. The skin and venous pressure was monitored during the session, and check-ins were done to monitor for pain, numbness, and tingling. Okay, so this is our results table. It's pretty simple. So our first one is extension range of motion before the BFR, extension range of motion after the BFR on each day, and then also the patient's pain rating that day. And I'll discuss a little bit more. So we were trending in a positive direction with gaining full extension range of motion, as you can tell by this table. So we kind of started around like 12 to that 8 was kind of random, but we started around like 12 to 10, and then we dropped slowly down to around 7 or 8 of the extension range of motion before BFR. So we were retaining some of that. And then by the end, we did gain 3 degrees of extension and got him within that 5 degrees of normal like we were wanting to do. There was no trend in pain ratings as the patient didn't really have much pain before we began the treatment. He also noted that there was no pain during the treatment as well. So like I mentioned, the initial range of motion did improve from the start of the study, and we gained 3 degrees from the first post-BFR measurement to the last. In comparison to other studies, this was kind of difficult to do because, like I mentioned, a lot of the studies were comparing strength and hypertrophy and muscle cross-sectional area and stuff like that, and using those as an outcome measure rather than range of motion. So we couldn't compare that too much. As for the one study that did use range of motion, it was comparing it to a control or to a different group, which we couldn't really do since it was a single case study. Again, the pain ratings didn't really correlate because the patient didn't have too much pain that we could assess, which is a good thing, of course. Inconsistencies and errors, scheduling and consistency of treatment became a problem for us just because the athlete was in season for the first half of the treatment and was still traveling with their team. So sometimes we wouldn't be able to do the twice a week. Sometimes we'd have to skip a week due to PT availability or whatever it might have been. So we didn't really get consistent on that 2 times a week until we were about halfway through the study. There could have been some integrator reliability error as well, because the PT that was doing the rehabilitation before the BFR session was the one that took the range of motion before, and then the other PT that was doing the BFR took the range of motion measurement after. So there could have been some slight variability there in how they took their measurements. Also conflicting variables. We cannot conclude that the BFR was the sole reason that he improved his range of motion and extension, as we did have an ongoing progression of rehabilitation techniques and other stuff that we were adding as was appropriate in his stage of rehabilitation. So in conclusion, I believe that blood flow restriction training can be used as a tool to improve range of motion. As from the studies, as I learned from the studies that I researched, it does improve strength, it improves neuromuscular control, is a good way to control pain, and a good combination of those things can help us to improve range of motion. The patient has continued BFR and will continue to do so until it is no longer appropriate, and the range of motion is continuing to improve. And then BFR application to clinical practice. Like I mentioned, this is a really good tool to use in surgical patients, not only in the lower limb, but also the upper limb, because they can get those hypertrophy and strength gains without doing the heavy load resistance training that they may not be able to do. But one thing that I mentioned a few times that we weren't really able to use in the study was the pain control. There was quite a few studies that talked about being able to control your patient's pain, both while they're doing the exercises and then providing that relief after. So stuff like tendinopathy would be a good reason to use BFRs, because you can control that pain while you're having your athlete do those eccentric exercises that they need to heal that tendon. And my references. And I'd like to thank Mike Marquis, Pam Abbott, Jonathan Birch, and Anthony Breitbach for their assistance. Thank you.
We have a question from the chat.
Okay.
How does range of motion inter-rater reliability impact the findings? Was active range of motion or passive range of motion changes measured given the hypothesis of the neuromuscular effects? Or intra-rater reliability impact the findings?
Can we do one question at a time?
So, no. He clarified his Okay,
Okay, first question.
so how does range of motion intra-rater reliability impact the findings?
Intra-rater reliability?
Yeah, or he may have been asking
Inter-rater.
Yeah.
Okay, so there were some differences that we noticed because on some days the AT staff would measure like the range of motion when he wasn't going to PT or BFR, and we would get closer to like 0 or 1 degrees, whereas the PT doing the BFR measurement the previous day may have gotten like 3 or 4, and then the next day like they would get like 3 or 4 as well, whereas we in between were getting like 0 to 1. So there could be those differences in how people measure. So that could have affected how much of an impact the BFR did have. So if the PT before that was measuring before had measured both, or the PT after had measured both, there could have been more consistency in that.
Oh, and he also asked the intra-rater, so the same person.
How would that have affected it?
Yeah, reliability. Did you see more trends in was there more consistency with specific clinicians? Around that, those trends around that?
It was definitely a little bit more consistent. So like if I go back to that table, yeah, okay. So yeah, there was a lot more consistency in the measurements after BFR versus the measurements before BFR. I wouldn't put that to the intra-rater reliability. I would more so explain that as being a difference in the athlete's activities before they had come into rehabilitation in the first place. So for example, if on a day that he had just rolled out of bed and come in, he would have been a lot more stiff, and that would have been probably one of those 12-degree days versus if he had class in the morning and he had gone walking around and he had lift or whatever it might have been before, that might have been a lower one. So I don't think there was too much error with the intra-rater reliability. No, was the other question?
Was both active and passive range of motion changes also measured?
No, so we did active range of motion measurements only.
Yeah. Any other questions? Question.
How do you know this actually is like better than like just regular exercises while doing the same stuff?
So can you repeat your question? Like, how is this better than just doing normal range of motion
like,
exercises?
Is it actually better, or is it just reduces pain while doing exercise?
That's a great question. So like I mentioned, we tried many different rehabilitation techniques. We tried a bunch of different range of motion exercises. We tried passive stretching. We tried a joint activation system brace, which is, I don't know how familiar everyone is with it, but basically it locks the patient in and then they can kind of crank it and it pushes them more into that range of motion. Along with those other range of motion exercises, BFR can just be an added benefit into creating more progress towards that. So we're still doing those range of motion exercises and we're still doing the strength exercises that we talked about before, just with that added cuff, because it adds, it causes the patient to fatigue more quickly. So they might not have to do as many exercises, or they might not have to do as high of a difficulty of exercises to achieve those same results. Does that answer the question?
Yeah.
Okay.
Good. Last but not least, Michael Ryan.
All right. So I did mine on concussion evaluation in the athletic setting. So I kind of defined athletic setting, not in terms of like practice, but more in terms of game. So evaluating like sideline and everything like that, just to clarify. So you guys should be able to describe what defines a concussion. I know everybody kind of is, had or seen a concussion. They're like, oh yeah, I got hit in the head and my head hurts, which most of the time that's what an athlete will tell you, but you never know. Describe the different assessment methods used for evaluating concussions. Describe the method for better evaluation based on the research that I found. So what is a concussion? So under the NATA guidelines, it is defined as a trauma-induced alteration in mental status that may or may not involve loss of consciousness. Athletic trainers are generally the first line of defense. So oftentimes, we do have team docs at a lot of different places, but if you look at the high school setting, most of the time, the athletic trainer is the only person on the sideline. So when an athlete gets hit in the head and they get taken out, the athletic trainer is usually the first person that they will go to, and you have to be the one to evaluate to allow them to either enter back into the game or keep them out for further evaluation. So I chose this topic just because in my own clinical education, I've seen multiple different people do concussion evaluations in different ways, generally hitting the same type of process, but not really consistent. So I just wanted to see if maybe there was a way to kind of conform everybody to a similar type of evaluation and maybe kind of bring up standard of care. So tools used for concussion evaluation in a clinical setting, most of the time when you're in like the AT room, you will use things like SCAT-5 or impact testing, and oftentimes post-concussion symptom scale too. All of that it's good, but it's hard to be portable with that kind of stuff. So if most people that I know don't carry around like a stack of SCAT-5s when they're out at a field. And then impact testing is all done on a computer, so you can't really bring a computer out to a field too. So how are you going to be able to compare the two beginning and end of pre and post concussion if you don't have those things available to you? So limitations on that, like I just said, non-portable in nature. So tests used for concussion evaluation in athletic setting. Usually most people will do like a functional movement assessment, having them do, running up and down the sidelines. For like football, you kind of have them put their pads on and just not hit anybody, but just kind of get in their stances and, cut, do things like that kind of get the heart rate up, and you see if you kind of increase symptoms or even have symptoms appear from that. Another thing is cognitive testing. So a lot of the times you'll come up and you'll say like, do you know where we are? Do you know who I am? What the score of the game is? General questions like that, just to see if the athlete is confused at all. And then generally a symptom checklist of just common concussion symptoms. Does your head hurt? Are you dizzy, nauseous? Are you sensitive to light or sound? Confused, or even some cases show amnesia where they will get hit and they'll be like, what happened? I don't know where I am, things like that. So limitations to that include there are a lot of pressures and distractions. I know in personal experience, I've been on the sideline evaluating a player, whether that was a player that I was directly involved with or of the other team. And I have coaches around me and other players coming up like, are they good to go? Are they going to come back? Like, we need them back in the game. How soon can you finish this up? And that kind of rushes our process to ensure the safety of the athlete. We have to not be rushed and have to be able to fully evaluate them without those pressures. So NATA guidelines recommend using symptom checklists, neuropsychological testing, and postural stability assessment. However, only 3% of ATCs surveyed in one of the studies that I had were following the NATA guidelines. Most people had some variety of that. They would do the symptom checklist or the neuropsychological testing, but not every person hit all three boxes. So that would mean that, say we were a room full of athletic trainers, or in this case, future athletic trainers, we all could potentially have a different method. So you never know, say I'm working with an athlete and they're like, well, that's not usually what people do to assess me for a concussion. Or they start to, you never know who you're doing the assessment on, like what they're used to and how they will respond to it. So guidelines are not followed just because they aren't really enforced. They are guidelines, they're not regulations. Infrequent updates, outdated research, or even I had, contradicting information from a few sources that it was kind of saying similar things, but just slightly different that could affect the outcome of the evaluation. So for my methods, I searched PubMed for articles including concussion, evaluation, athletic trainers, athletes, and specifically return to play. And I just kind of said anything past 2000. These search parameters provided 37 results that I then went through and looked at and kind of adjusted to what my questions were asking and specifically going to the sideline evaluation. So results. Concussion evaluation is important because misdiagnosis could result in further brain damage. So say you have an athlete and you're feeling that pressure to send them back out on the field, and you send them out and then they get hit again. Then they come back, and that's how you get the second impact syndrome. Or if they're not fully recovered, then you can, due to multiple head traumas, eventually get chronic traumatic encephalopathy, commonly known as CTE, which is kind of a hot topic with like NFL and just general concussion evaluation talk. So it should contain multiple steps, starting way before the athlete's even injured. So if you start with like pre-participation exam questions of just trying to find a baseline of assessing them in like best testing and, just those general assessments that can have you seeing like, okay, this is normal, this is not normal. And just, I believe that every athletic trainer should do those with their own athletes just to see, so your athletes better, what they're doing, what their general tendencies are. Education is huge. So telling athletes, these are the symptoms you need to look for. This is what you might be feeling. And then mostly just saying risk. Like athletes are, they might lie to you about whether or not they have a headache or whether or not they're dizzy. But if you tell them the risks, like, hey, if you go back in, this could cause some serious damage that would really, really impact you in your future. Letting them know that and making sure that they're aware of that could prevent them from, I don't want to say lying to you, but omitting the truth from you. And then obviously the assessment after the head trauma to ensure that you are evaluating for a concussion. So, like I said, baselines for best and impact testing, along with a questionnaire about general well-being, should be included. I already kind of covered education, so we won't worry about that. Assessment using multiple methods, including the symptoms checklist, the cognitive testing, functional movement assessment, provides the best chance at diagnosing a concussion if one is present. So obviously, you're not going to be diagnosing somebody with a concussion if they don't have one, or you shouldn't be, but this will at least help to find those like little outliers that don't necessarily present in the normal way. So I believe that implementing legislation that requires a standard protocol for concussion evaluation, as well as a pre-participation exam and education, would improve standard of care. So if everyone is kind of on the same umbrella of you do this first and then this and then this, then there's no surprises and everyone is kind of on the same page. So the more we know about a player before concussion, it can help us to assess them more accurately. And then having a regulated protocol that is practiced consistently will result in less pressure being felt during the sideline evaluation. So if the coaches know what you're doing, they have been taught the process, they know what you're doing, they know what is a red flag and what's not, they're less likely to come up to you and be like, are you done yet? Like, what are you doing right now? Like, they won't have as many questions so that you won't feel those pressures from them. And once that general protocol is kind of shared between coaches, players, and even fans, people won't pressure you into rushing a decision. They'll be like, I'm just going to let him finish his process, and then he'll have a set of whether or not that is going to keep a player in or out. So in conclusion, head injuries are one of the most dangerous injuries possible because they generally don't present in the same way person to person. I could get hit in the head and have, all the common symptoms, dizziness, sensitivity to light. I could have a headache, all that. But then, say Mace gets hit in the head and he doesn't present with any of that stuff, but his, balance is off, or he's, just not quite right. Those kinds of things, those kinds of sayings are hard to define, but they're also important to making sure that your athlete's not going to go back in and be in further danger. So we are the first line of defense against further brain damage. And that is just, again, we're usually the only ones on the sideline evaluating people. So if we evaluate someone properly and we make sure that they are able to assess properly and the athlete is going to report properly, then we can be able to further evaluate them and make sure that they aren't going to go back on the field. if they have a concussion. Having set protocols that are required to follow would break down pressures felt by athletic trainers. So these are my references. And then I'd like to thank Dr. Tony Breitbach for his help with me on this project. He kind of steered me in the right direction on how to kind of go about talking about all this. And then Sean Wright, who is a former preceptor of mine, he definitely gave me the idea for this presentation and kind of pointed me in a direction, I guess. And I didn't put it up there, but I would like to thank my classmates and family and friends and everybody just for supporting me throughout all these times.
We do have a comment from the chat. There's some new concussion evaluation tools that are starting to come out. One of them is called SportGate. That utilizes a lot of these recommended components. So that might be. So do you think every concussion is different because of our working definition is incorrect? Concussion is a mechanism of injury and not a diagnosis. So do you think that there's some issues with the consistency of even naming them, head injuries?
So in my research, in multiple different articles, I found different diagnoses for concussions. Some of them, most are going away from saying that they had to lose consciousness. But I remember you telling me, Tony, you were like, it used to be if you didn't lose consciousness, they didn't really think you had a concussion. And now people are generally moving away from the term concussion more towards traumatic brain injury or head trauma, things like that can sort of move those diagnoses or the lost my train of thought there. Sorry. Just kind of pushing everybody towards the same definition. That way everybody can be on the same page with everything.
Any other questions? Grace?
For pre-participatory examinations, would you like to take previous ones and agree on one that everyone would use universally, or would you like to combine different aspects of them, or would you create a different one?
So I would generally want to have a committee of people put together to kind of design all of this, the protocol and design the proper pre-participation exam as well as education standards, just so that everyone's following the same thing and we're having the proper professionals make those things for us. Obviously, we want a lot of athletic trainers on that committee, but as well as team physicians and just those general medical professionals, just to kind of be together and provide that information. Anybody else?
Yeah, I think we're good. I'd like to congratulate everybody on an excellent job on their capstones. Very good, very good. We do have pizza from Vito's for everyone. I request that you let the graduates go first, and then everybody else can grab pizza. And then once everyone's kind of grabbed some food, we're going to do a little recognition ceremony. So help yourself and good job. Time to turn all this stuff off.
That's what's on the schedule.
Yeah, 5 to 3.
Okay.
Yeah, yep, thank you. Yeah?
I can't fill this one out. I get this. I don't know what's going on.